So may I request our respected President of Indian Association of Biological Psychiatry, Dr. U.C. Gog sir, to deliver the welcome message for today's First Friday CME for the month of June 2022.
Thank you, Prasanjit. Good evening and hearty welcome to all participants, especially our learned speaker, Professor Arshad Hussain, and our eminent chairpersons, Professor Shobha Nair and Professor Nitin Gupta. Today, we are missing our regular host, Dr. Ruxida Saida, because of some commitments, but definitely she is there to encourage the participants and speakers. As you all know, polycystic ovary syndrome is a complex genetic disease that affects approximately 7% women of reproductive age worldwide. It is a heterogeneous disorder and also accompanied by an array of symptoms such as obesity, acne, scalp hair thinning. Many women with PCOS report clinically significant symptoms of anxiety or depression. In fact, they are 3 times more likely to be diagnosed with anxiety and depression in comparison to women without PCOS. We also know that different studies have observed women with PCOS having several HPA changes like abnormal androgen synthesis and secretion, enhanced peripheral metabolism of cortisol, and impaired feedback inhibition, which all are likely to be seen in patients with major depression. Not only this, there are concerns which are not related to any psychiatric diagnosis like marital or family or social issues, low level of quality of life, low self-esteem, which can be associated with PCOS. Thus, given the seriousness of anxiety and depression and other mood symptoms in women with PCOS, further study in epidemiology, clinical features, neurobiology, quality of life, and treatment in different settings is needed to better understand this syndrome. I'm sure that today the learned speaker, Professor Arshad Hussain, will definitely deal with these issues. I'm also very much thankful to Dr. Ruxida Saida, Honorary General Secretary of IABP, and Dr. G. Prasad Rao, Chairperson of CME Committee, to design a CME on first Friday of every month. I'm really very much thankful to all the members of CME Committee for choosing the topics which are very much relevant and very much related with biology, but are quite relevant in clinical settings of our colleagues. With these words, I again welcome you all in the first Friday CME of IABP. Thank you. Thank you, Dr. Prasanjit. Over to Dr. Prasanjit.
Thank you, sir. Thank you very much. Today, our speaker, as sir has already said, is Professor Arshad Hussain from Srinagar. And we have 2 very eminent personalities as the chairperson for today's CME. Dr. Shobha Nair Madam from Mumbai and Dr. Nitin Gupta sir from Chandigarh. Dr. Shobha Nair Madam is head of the psychiatry department at Bark Hospital, Mumbai. She is also PG teacher and guide of DNB students, and she has around 25 years of clinical experience. I welcome you, madam. Our second chairperson for today's evening, Dr. Nitin Gupta, who is also a senior dada for me. He is into full private practice since 2019 at Chandigarh. Before that, he was professor of psychiatry, Government Medical College, Chandigarh. Earlier, he also worked in NHS Trust in Stafford, England. His areas of interest are psychotherapy, adolescent psychiatry, and clinical psychopharmacology. He is the recipient of various awards, including Kataria Memorial Golden Award. He has around 240 publications, and he has co-authored around 6 textbooks on mental health. He is the editor of Indian Journal of Social Psychiatry, Indian Journal for Indian Association of Child and Adolescent Mental Health, and is also the co-editor of Journal of World Association of Social Psychiatry. The list is endless, so I'll stop here and I will hand over to our distinguished chairperson for further proceedings. Thank you.
Do I start, Dr. Prasanjit?
Yes, madam, please go ahead.
Thank you, Dr. Prasanjit. Good evening, Dr. Garg, President of IABP, my senior colleagues, friends, and everybody who is attending the program today. At the outset, I would like to thank Dr. Rukshida, Honorary Secretary of IABP, and the organizing committee for inviting me to chair this session. And that too, I'm extremely privileged to be co-chairing it with Dr. Nitin Gupta, whose CV is just astounding. Today's topic in the First Friday CME series is Mood Anxiety Complex of Polycystic Ovarian Syndrome, which has been briefly introduced by Dr. Garg, extremely relevant to adolescent and women's mental health, especially in the reproductive age group. As we all know, PCOS is on the rise. It's the commonest endocrine disorder in women in this age group, and also the most common cause of female infertility. Similar to other lifestyle diseases, PCOS has a chronic course. It has a long-term impact on various aspects of one's physical health as well as psychological health, and thereby affecting one's quality of life. Now, how common are these mood and anxiety disorders? What is this mood anxiety complex? Are they the result of cultural feminine stereotypes and societal expectations from female gender? Or are they more biological in origin, related to stress hormones, insulin resistance, etc.? How do we manage patients who suffer from psychiatric disorders? What is our role as psychiatrists, and how can we improve the quality of life of this population? To shed light on all these aspects and give us a very comprehensive understanding, we have Professor Dr. Arshad Hussain from the Institute of Mental Health and Neurosciences, Kashmir. And it was a surprise to me in the morning. I was just trying to, scroll through some studies, Indian studies, if they are. And I was surprised to see that he has himself conducted a study on about 110 patients of PCOS, along with a control group, and published mood and anxiety symptoms in this subgroup, an original research article, along with other colleagues from his institute, in the Indian Journal of Psychological Medicine. So today's session, we look forward to not just the academic inputs and the recent advances, but also your valuable experience in this area. Thank you so much. I now hand over to Dr. Nitin Gupta to formally introduce our speaker. Thank you.
Thank you very much, Dr. Nair. It's a pleasure to be co-chairing this session along with you. And also a pleasure to introduce Dr. Arshad Hussain, a dear friend of mine, and we have been working together in various capacities. As Dr. Shobha Nair has mentioned, Dr. Hussain is a professor at the Institute of Mental Health and Neurosciences, Kashmir, and is working in Srinagar. He's a gold medalist from the same institute, passed out in 2005. He's got varied areas of interest and expertise like trauma, bipolar affective disorder, metabolic syndrome, and neurocognitive disorders. He's published reasonably extensively, and Dr. Shobha Nair has already mentioned about his original work in PCOS. He's carried out various research-funded projects at the level of ICMR and WHO both. He's been awarded various fellowships like the Japanese Society of Psychiatry and Neurology, the Fogati Fellowship, the WASP Fellowship, to name a few. He's affiliated with various organizations. He's quite active, and currently he's also the chairperson of the awards committee of the IPS North Zone. With this brief introduction, I would welcome Dr. Arshad Hussain to today's academic activity and would request him to do his presentation. I'm sure it would be very enlightening and we look forward to his presentation, and we would hopefully have a lot of interest generated in the form of questions and answers, which we will take up later on after his presentation. Dr. Arshad Hussain, please.
Good evening, friends. Good evening, Dr. Garg, President Indian Biological Society, my chairpersons, Dr. Rukshida, Dr. Garg. It's indeed a pleasure to be here because I have been part of biological psychiatry from a long time. In fact, I had been secretary for 2 years. I had been joint secretary for 2 years. So today presenting one of my favorite topics, which is sort of deviation from normal psychiatry in a sense that we're crystallizing PCOS in a very different way than people understand polycystic ovarian syndrome. So, even though polycystic ovarian syndrome is sort of a new disorder in the sense that most of the research has started very late into it, but there are some mentions of polycystic ovarian syndrome. For example, if you see this Valesnarines, an Italian medical scientist described about it, then you have Shadow and Rocketetsiki talking about the fibrous sclerotic lesions in the ovary. You have Larson Tate presented a need for oophorectomy for these symptomatic degeneration of ovaries. You had partial resection of ovaries as proposed as one of the treatments. But serious attempts to understand PCOS started with what we call now Steen-Leventhal. In fact, all of you will be knowing that people used to call polycystic ovarian syndrome as Steen-Leventhal syndrome as well, wherein they started describing women with menstrual disturbances, hirsutism, and enlarged ovaries as polycystic ovarian syndrome. As recent as 2003, probably there was some serious concerns about how to diagnose polycystic ovarian syndrome, how to develop consensus guidelines. And in 2003, we had, in 1990, probably we had NIH guidelines. Then in 2003, we had Rotterdam Consensus Conference. In 2008, again, we had, again, some 2012 to 18, we had again some NIH guideline changes about polycystic ovarian syndrome, because this is a very evolving science of polycystic ovarian syndrome. So you'll see prevalences. If you look at prevalence, what's very important to understand that polycystic ovarian syndrome is the most common endocrinopathy of fertile age group females. That is, you might see it in different ranges depending upon what criteria had been used to actually diagnose it. But generally, the consensus is that this is one of the most common endocrinopathy in the age group where the females are fertile. So, the ranges could be between 6 to 10%, are in fact somewhere higher as well. One of my co-researchers who used to work in AIMS and now works in SCIMS, Dr. Ashraf Ganai, with whom I'm closely linked in almost all PCOS research, is somebody who does extensive research on that. So one of his papers actually speaks about 3.7 to 22%, depending upon what criteria they used. Regarding diagnosis, we had 1990 National Institute of Health criterion of wherein there were 2 criteria of hyperandrogenism and menstrual irregularities. Then, in 2012, they probably changed it and added the polycystic ovaries as well. We had androgen excess PCOS criteria society, which talked about hyperandrogenism, menstrual irregularities, all or polycystic ovaries on ultrasonography. Then we had Rotterdam criteria, which actually talked about 2 out of 3 criteria, which is almost the same with NIH as well, of hyperandrogenism, menstrual irregularities, and polycystic ovaries. Hyperandrogenism, which is either clinically demonstrable by means of hirsutism, acne, androgenic alopecia, acanthosis nigricans, are laboratory values of high circulating levels of testosterone or androstenedione. Menstrual irregularities in terms of oligomenorrhea and amenorrhea, all lab values of high levels of luteinizing hormone. Ultrasonic findings classical are greater than 12 follicles in each ovary, and follicular size generally between 2 and 9 mm, and volume, our overall volume of ovaries of 10 ml. And what does that all lead to? The consequences of polycystic ovarian syndrome. You have irregular periods, you have weight gain, you have hair loss, you have acne, you have hirsutism. But more important than that, at different times of the age span, for example, in early adolescence, you have clinical hyperandrogenism and oligoanovulation. Then in 25, 30 years and the ages in that area, you have infertility, you have hyperandrogenism, you have pregnancy complications. Then you have, if you go a little bit later in the age, you have hyperandrogenism and glucose intolerance. And you go later in the age and you have cardiovascular diseases highly associated. You have type 2 diabetes, you even have cancers associated with it. So the consequences are multiple, from insulin resistance, which has been closely linked to PCOS, not only as a consequence, but there are various theories which actually talk about insulin resistance as the cause of PCOS as well. Obesity, which is very central to PCOS understanding, and dyslipidemia, cardiovascular illnesses, and other effects of hyperandrogenism. All of that, and then them being linked to subclinical, cardiovascular illnesses or clinical cardiovascular illnesses. You go through any endocrine society guidelines currently, you'll find that in almost every guideline, in almost every clinical paper on PCOS, at the end, they will talk about psychiatric or psychological impact. And that's why we started our work. All guidelines now talk about high psychiatric morbidity in them. And in fact, most of the guidelines recommend, while they recommend screening for cardiovascular disease, diabetes, they do recommend screening for depression and other psychiatric illnesses as well. But the understanding of, because the view comes from endocrinologists, the understanding usually is because PCOS is very disabling, psychologically distressing. There's an impaired quality of life. There's distorted self-image. There are fertility problems, and that's why probably there is higher psychiatric burden. And that's what's almost universal understanding. Even though there's certain, when we started challenging this dogma, there were not many challenges to these ideas, but now there are more challenges to the idea that the psychiatric burden in PCOS is just because of impaired quality of life and the fertility problems. Again, reduced quality of life in PCOS leads to depression, anxiety, aggression, bodily pain, infertility, weight gain, all of that actually leading to psychiatric morbidity. And that's what we actually challenged almost outrageously. First, because people were not able to accept it. And with new research, in fact, probably we are getting nearer to what we thought. What we thought that, in fact, that PCOS is seen mostly in the endocrinology clinics. And most of them concentrate on the consequences which I talked about, the obesity, the insulin resistance, the diabetes, the cardiovascular diseases, the fertility. They do see sometimes distress, and they think of it as I explained, that is because of the fertility issues, the quality of life, the self-image, or the burden of the disease per se. What they probably don't know that many of them are going to psychiatrists as well. Same female. And many times patients just don't talk about it. Why should I talk to the endocrinologist about my psychiatric issues? Or why should I talk to the psychiatrist about PCOS? We see them separately. It's like same as, that old story of when the blind went to see the elephant and the part I touched was the elephant. Absolutely like that. And we also thought like that. When we did our first study, we had high morbidity, psychiatric morbidities, and we thought, we also thought of the same, that this is because of burden, this is because of self-image, and all that stuff. Till we went to this second study. This second study opened new realms for us. We started thinking of PCOS very differently than people think of PCOS and psychiatric morbidity. And many things which challenged our usual viewers. For example, people, as all of us as psychiatrists know that, we link valproate with PCOS very much. And because we were studying bipolar affective disorder, so valproate was part of this whole study, and along with other mood stabilizers as well. We found that while valproate, we did see patients with on valproate having PCOS, even though I understand that many of the studies we talked about PCOS and valproate initially were from epilepsy background or seizure background, and the years of using valproate was more than 3 to 5 years. But in our study, we did see that use of valproate even for a lesser duration of time was linked to somehow PCOS. But we found stark differences between different groups of women. For example, we found stark differences between urban and rural women. While rural women on valproate for years together did not develop PCOS, but urban women, even on quetiapine, which was thought to be quine, it's very woman friendly, having PCOS. And many other challenges as well. We thought that, we started thinking of, while we dealt with PCOS and bipolar, we started actually thinking of the association between the two disorders much beyond simple burden of disease or infertility or, the self-image. And we started thinking of making this new concept of mood anxiety complex of PCOS. We said that PCOS is fine, but probably the link is much more than what we generally think of. We started going a little back and we started thinking about that how there's a parallel global trend of increase in metabolic disorders and mental health problems. And how we see them in different clinics, in different perspectives, and never think of that they might be from the same etiopathological backgrounds. How we never think of that, even though there are many pointers towards that same kind of etiopathological mechanisms might be actually responsible for this parallel increase in the global metabolic disorders and the mental health problems. And we started looking at these mechanisms. What could be the possibilities? So all of this is hypothesis. Even though in rat models currently there's a lot of research. I never knew that people will actually one day start accepting these models. So there's a lot of research, in fact, going on currently in this field. And we started looking at our data, and we started looking at the food habits of our patients. We started looking at the sleep habits of, we started looking overall, and we thought that there definitely seems to be an environmental hit. And most of the environmental hits seem to be such hits which will hit your brain first before it actually hits your ovary. And we started pursuing PCOS in a very different ways than we were looking at it. And now onwards, for everybody who's listening, please carefully start following your young females who come to you with anxiety issues nearing adolescence, or even pre-adolescence, or mood issues nearing adolescence or pre. Start following them many times. I should not sound outrageous. Most of the times, they will get a diagnosis of PCOS at some point of time. And that's how we started actually thinking that while you think of various factors from hypothalamic pituitary axis to hypothalamic pituitary gonadal axis, leading to stromal secretion of androgens and then its effects. But while the hits are more close to the brain, why don't we think of neuroglial stimulation and the androgen release first? The first androgen spurt start in the brain is the brain signal for starting of PCOS. And all of us know that the androgen receptors and effects of androgen on behavior and effects of androgen then on the whole body, we already know. But hits which come might actually be perceived by the brain first. So the androgen release might be much earlier in the neuroglial cells than it will actually happen in the stromal cells. Or else, when the stress starts piling up, the hypothalamic pituitary adrenal axis might actually start sending signals to the gonads before actually gonads start affecting gonadotropins and LH and FSH start its effects on the body. There might be things coming out in the brain as a signal to start of a process of a syndrome of a multitude of symptomatology which might actually come in the future. It looks like the same chicken and egg story, that what came first. While most of the endocrinologists think of that the PCOS came first and the MAC PCOS which follows it, but I'm a strong advocate of that is the MAC which actually starts and then the PCOS follows. And what are its implications? The implications are that are the psychiatrists seeing these patients at a much earlier stage where the further issues are preventable? Do we have means and ways to do that or not? Can we look at that? And when I said means and ways, and not essentially biological, for example, have we seen that how exercise, change in food habits, and all of the things at that point of time when the signal starts will prevent PCOS or not?
मुझे भजिया ने फोन किया लेकिन इसको आवाज कम हो गई। मैंने
And
इसको बोला 1 घंटे के बाद मेरे साथ बात करो। पता नहीं इसको आवाज
then
नहीं
the second thing is that my search for a male equivalent. While there's already some consensus developing that PCOS has a male equivalent in terms of endocrinopathy, but male equivalent in terms of psychiatric morbidity. No longer are we in times where depression was thought to be the illness of middle-aged females. No longer are we in those times. All of us, know that how many young people you see from adolescents starting with anxiety, depression, after some time developing metabolic syndrome, after some time developing diabetes, then hypertension, then cardiovascular disease. How commonly all of us see that. And are we in search for a male equivalent? And is that search also linked to psychiatry? That how we will be able to actually, again, the signal starts in the brain, and how we can stop the heralding effects of stress, internal, external stress. I do not understand only as a stress in terms of, how you see the internal stress of inflammation, the internal stress because of, the hormonal changes, the stress created by foods, all of that, and how that starts that signal in the brain, and how that actually leads to all other processes, including the rise in the metabolic syndrome, as I said, the parallel rise in the both, which is actually going on in the both areas. We even have, because I have not had a slide for this, but we almost have discerned the symptoms of this MAC Pcos, as I was saying. For example, these young females might look to you initially, anxiety, obsessiveness predominant, depression, but mood changing in very, very fast, looks like borderline. And sometimes, if you see them in a stage, cross-sectionally might look like bipolarity. But then, they keep a very stable position for a long time for this. And we could reflect on our earlier studies that why did we had this anxiety pattern in them, high anxiety pattern in them, high obsessive pattern in them, and high bipolarity pattern in them. But this seems to be an illness of its own, rightly. But people who have genetic predisposition, for example, for developing bipolar, they might actually later on actually herald to bipolarity. Actually, generally, people have anxiety, they have obsessiveness predominant, they have mood changes which happen. And in fact, in the treatments also, we have graduated a bit. We actually work with SSRIs with them, and we see very less percentage of these people actually getting activated SSRIs. We see many of them actually settling in their anxieties. We have used lots of sertraline in them. We do use lamotrigine, particularly if the families have history of bipolarities. Then we might use lamotrigine. And what do we see with the treatments? We do see some hope with the treatments. For example, many a times females who are, as I showed you in that slide of 25, 35 age group females, which were referred to us with PCOS and psychiatric morbidity, were going to fertility experts for fertility. And we told them, please hold on for some time. We'll treat your depression, anxiety first, and then you try. And they coming after within 4 to 6 weeks and giving you a good news that, a bad news from them that, sir, please, we couldn't hold on, because what happened that I suddenly realized that I have got pregnant. Nothing had changed. And the only thing which happened that the mood anxiety complex actually has been addressed in ways which has actually led to, as we hypothesize, has led to the stress homeostasis in the brain, which has led to the neuropeptides, which actually were leading to the infertility environment in the brain has been gone, and they suddenly become fertile. You'll see many of these, when our eyes open, we'll see many of these things happening. Infertility couples of 5 years, 6 years coming to us and suddenly realizing that they have got pregnant just by simple treatment of mood anxiety complex. And more important than that, does studying PCOS in the way we are thinking of it as MAC PCOS provide us with an opportunity to look at the etiopathogenesis of mood anxiety complexes at all? Because as we see rise in this mood anxiety complexes all over the world, depression, the commonest in this illness in the world, we do understand, we put urban lifestyle, we put stress, but how does it affect? How does ultimately it do it all? And does PCOS provide us a unique opportunity where there's a phenotype known, and we only need to now look at the brain as the signal and the start of the illness, and we could actually move on from there and probably develop the interventions of a kind of type which are needed not only to prevent mood anxiety complex, but all metabolic disorders. Can we do that? And some years back when I used to spoke about it, I thought we are too distant. But currently the studies I'm reading particularly in the rat models which are being done, I don't think we are very, very far from that. I think we are right there. At one point of time, we will have known the pathogenesis, and at one point of time, we will have interventions which will not only prevent the mood anxiety complexes, but also prevent from there onwards the path of metabolic, which goes ultimately to the cardiac deaths. Probably we will be there one day. Thank you so much for listening to me so patiently. I know, some of the concepts we have developed are outrageous. We still have to prove them. We still have to put them into test. But I sincerely feel that we are on a path, and we probably are on the right path. Every new research which I see actually makes me to believe that. Thank you so much. I'll be ready to answer any queries on that, whatever I know about the LS. Thank you so much.
Thank you, Dr. Arsad, for such a nice deliberation.
Can I speak?
Yes, madam, please.
Dr. Arshad Hussain, you've completely changed the perspective that we had about PCOS. It's amazing. Your second study on bipolarity and that how valproate in urban versus rural, that's something very, very interesting. But isn't PCOS per se a disease of the urban industrialized world, just like all other lifestyle diseases?
Exactly, ma'am. Exactly, that's the point. When we say of a spasm, for example, another group, I missed this. I'll say that first and then actually answer your question. Have you ever looked at air hostesses?
Yes.
And have you ever seen an air hostess without PCOS? The external segment of PCOS, and how the circadian rhythm disturbances in them, in terms of sleep deprivation, actually leads to the PCOS. Not studied much, something. And I same to answer the question that it is an illness of a particular group, and you have to find that etiology of that. What is happening in that particular group? In contrast, and what is changing? Our food habits are changing, our sleep is changing, and all of them are perceived by the brain first before they are perceived by the ovary. That's my point precisely. That why don't we focus on the brain first? We say that stress, we say that sleep deprivation, we say that food changes, but what perceives those changes first? The ovaries or the brain? And if it's the brain perceiving them first, is the prevention there then? That's the point.
So when we look at it, say evolutionarily, we can say that the rapid changes that human species has had to adapt to with the urbanization takes a toll in a small percentage of people who are unable to adapt in whatever way they ought to, leading to.
Absolutely, ma'am Nair. Just look at this. The first hit to the sleep came with the Edison's bulb. So as so we structured it a bit. We were programmed to sleep at dusk. We structured it a bit. Then we structured it a bit more. The human body, the brain is a dynamic process, so it started adapting. Now I do not sleep whole night, I sleep whole day. Probably brain is not there. The brain is not able to actually adapt to that homeostasis. It's not able to get that homeostasis back. And that's why the neurohormonal, go every, and that's where is the genesis. The human is very dynamic, it can adapt, but that adaptability also has a limit.
Yes.
So probably when we reverse it, I do understand that genetic predispositions, I fully believe in that there are genetic predispositions, but then that genetic predispositions are exhibited once the environmental insults start. And when the environmental insults start, the type of pattern that the human body is not able to adapt.
Dr. Arsad, there is a question. Is the psychopathology of PCOS is more closer to unipolar depression or bipolar depression?
That's what I was, the symptom complex we are describing is that lot of anxiety of, the term I usually use, the pan anxiety, lot of obsessiveness, mood changes, because most of them actually come to the attention at the times of depression. But any one of them you talk, there are times when they definitely are hypothalamic. That's the complex, I'm saying. So generally it depends upon when do you see them. When do you see them is very important. In the families where there's history of bipolarity, very near to bipolar mood disorders, but in the families where there's no family history of bipolar affective disorder, the clinical phenomenology is as I described. A lot of pan anxiety, predominantly obsessiveness, and then mood changes, lot of depression, but sometimes hyperthymias, or sometimes you could actually go into hypomania-like illnesses.
What is the prevalence of irritability?
Very, very high. Probably, I deleted that one of the slides which was kept by my senior resident, wherein a scientist in 2000 actually has described them as, feverish females. I thought it will be really, I will be stoned out of the presentation. So I actually, so lots of irritability in many of them, which might be actually coming from the anxiety mood symptoms they have.
There is one more question, rather suggestion. Can we consider DAT syndrome as the male counterpart of PCOS?
No, not really. The male counterpart of the PCOS syndrome is same. Any psychiatrist who's working in urban settings and is seeing currently young men coming to him with lots of anxiety, obsessiveness predominantly, mood changes, looks like borderline males. That's why probably the PCOS, PCOS equivalent looks like. Because many of them, when you follow them, they develop very early hypertension, they develop early diabetes, and some of them even have cardiac deaths, very early cardiac deaths. And that's what is actually, and many of them usually come to, one that who will come early. And people who come a little later will come with young age depression. Young age depressions. And when you go in the history back, you see that they had started in adolescence with the kind of symptomatology I'm actually describing.
There is one more question from Dr. Rao. He's asking that, can we think of future studies about the effects of the medicines that are used for PCOS on mood anxiety states?
Yeah, there's observation only. This is an observation only. We have not compiled the data. We did not see that, once people are on treatment for PCOS, do not actually improve. But we do see that if you early treated, when you treat mood anxiety symptoms of people with PCOS, there might be some things in that. For example, they start exercising in a way that is important for them. They start adhering to the medications in a way that's very, very important to them. That has indirect effects on the PCOS. And I told you that with full confidence that you'll find many times PCOS which are referred to as psychiatrists for depression, and you started with them on a medication and they conceived after 5 years, 6 years, suddenly they started conceiving. And the whole PCOS infertility, that lockup which they were living in got shattered. They just got conceived. I have had many such incidents because I'm following lots of these PCOS girls. So I had many of such incidents where they were on sertraline, because we use generally sertraline in them. So they were on sertraline and suddenly they started. There's this many gynecologists who have started referring to me patients that when they have an infertile female, they do not know what I'm doing, but they started, the doctor said, write some medication, some of them do conceive. I've had many infertile couples actually referred for this kind of thing. After they had these patients being followed by the gynecologist for 2 years, 3 years, 4 years, and not conceiving. So, what I mean to say actually that improving brain homeostasis, decreasing brain stress has a positive effect on the PCOS person as well.
Dr. Alia wants to know, what was the prevalence of eating disorder in PCOS, whether you could find any correlation or link between the two entities in your research work?
I do not remember exactly, but we did have. Eating disorders. In fact, most the literature also describes lots of eating. Because we have to see one thing, that once we see lots of patients, for example, if I see 100 patients of PCOS, I will see a schizophrenia as well. so I generally do not link everything to the PCOS. So my concentration is on something which seems to be very new in PCOS, which seems to be very unique in them. I do see other illnesses. For example, I know PCOS with schizophrenia, I know PCOS with eating disorders, but my interest is in something new which I saw and which actually I want to put into, which I see very commonly in PCOS. I do not see any PCOS which does not have the course. I say there might be difference in the severity of the course, but the course is same. The anxiety signal from the brain has come much earlier than the PCOS symptoms have come. The intensity of anxiety might have been less, that's possible, but not that the absence. The absence is very, very rare. That somebody will tell you that at PCOS, I did not have anxiety. Very rare. I did not have sleep deprivation. No, very, very less people do speak about that.
There is one more question that psychiatric medicines do cause weight gain most of the time. Can you guide us regarding it? Because PCOS itself causes,
as we know that, this is again very interesting topic. Something which we have worked with, because my interest in psychoneuroendocrinology started with my thesis, because my thesis was on diabetes and depression, and that's what actually put me into this. Generally, absolutely yes. We do see many of our medications are linked with the weight gain, and we as psychiatrists should be very cognizant of that, and we should really take care of our patients in that way. While we know that there might be contribution from medications in the weight gain, but also understand that the illnesses we treat have per se greater chances of weight gain, obesity, metabolic syndrome. And I'll tell you one important point. Who were the first people in the world to talk about the metabolic syndrome? They were not the endocrinologists, they were the psychiatrists. We were the first to describe bipolar as a picnic look. It is in the times when even medications were not there. The picnic look was there. So what is picnic look? All of us know what is picnic look. So we have to understand, when we put this weight thing, we have to understand in that context. But, I fully endorse, probably Dr. Yatham said it in one of the meetings, I was probably invited to European Congress once for this travel fellowship, and he said that exercise is the most underutilized antidepressant. The point which I made of parallel metabolic and psychiatric rise, exercise might be another commonality, the lack of exercise. Everything we do in the modern world is the lack of exercise, from the vehicle to whatever has been put in, is the lack of exercise. We as humans were made to exercise. Our legs have been made in a way, our body has been in a way. We were made to walk. That was inherent to us. Humans had to walk. We gave it up. And by giving it up, what you change is the homeostasis, and that homeostasis changes everything, and that affects the brain as well. So once it affects the brain as well, so the mental health issues. So effects of exercise, effects of actually regulating weight. It's very important for us to talk to our patients about the weight while we actually deal with their depression. Till we have medications, probably there might be some offsetting by the medications as well. But overall, when you actually weigh the pros and cons, you will think that treating is better than not treating. Because, for example, you do not treat depression, his chances of developing a metabolic syndrome are much higher than when you treat it. Because he'll otherwise also not exercise. He'll otherwise also take lots of food. He will take more of junk food. So his chances of actually having so making people to adhere advices which are counter to actually improving metabolic syndromes or improving, their health, has the essence is the mood. If you put people out of in a good mood and you might make them adhere to your advice in a better way than you actually make them without that.
Thank you. Any preferred molecule, antidepressant, keeping in view the weight gain potential?
No, I said it that I have used, from my diabetes days, I used sertraline more. But I have started actually trying fluoxetine also a lot now. But this sertraline generally came from when actually they started, when females started consuming, all of us know that certainly there's a lot of evidence in its favor that it's more safer than other SSRI during the first trimester. So that probably came from that, and then it became almost a habit. I'm not averse to using other SSRIs, and I do think that I should try more of fluoxetine and gain some experience with that as well. But if I link the use of SSRIs with exercise and other things, I generally, and particularly the food habits, I really work in PCOS on the food habits. This is my, somehow in our culture, this is very common for patients to ask about parhez. So my parhez generally is that you cannot take now dinner. So dinner has to be an apple, orange, or watermelon. So this is general. So my patients generally are thinner, leaner, and exercising a lot. So they do not understand that I'm not, this is, I said that for treating depression, this is very essential. And, probably all of us need to make these habits of actually getting these changes, because in our culture, it's very common for the patients to ask us about, what do I eat? And I utilize that a lot. I utilize that a lot in my practice, and particularly with the PCOS patients.
We have two more questions, Dr. Arsad. One is the role of mindfulness in PCOS. And the second question is, any suggestion regarding putative biomarkers for PCOS?
Two wonderful questions. When somebody talked about mindfulness, in fact, as I said about, I started with exercise. Probably we as psychiatrists are in a position when we see these kinds of girls, we probably are in a position to prevent their further derailing towards metabolic syndrome, and we should utilize all the techniques which actually could, help in this, including mindfulness, including exercise, including, all cognitive behavioral therapy, whatever is available to us, to improve their health, improve their mental health, and in turn improve their adherence to for exercise, for taking healthy choices, for sleeping at proper time. All of that should be helpful. Even though I do not have, I have not done work on that, but I generally see that that's happening. Regarding biomarkers, that's such a wonderful question, because there are some. I was reading some of these neuropeptides which are currently under investigation in rats, in rat models. In future could be actually linked to as biomarkers. There has been some talk about dexamethasone suppression tests as well, but I don't see it. Probably in psychiatry we have not gone beyond depression, while it was a marker of melancholia. It didn't go anywhere. But neuropeptides currently, many of them are being increasingly actually thought as links between the stress. And when I said stress, is the stress caused by food, stress caused by sleep deprivation, stress caused by the other factors. All of that as affecting then the hypothalamic pituitary gonadotrophic axis, and then not letting it to actually shut off. And these neuropeptides might be the future biomarkers in PCOS and what I call as MAC PCOS.
Thank you very much, Dr. Arsad, for sharing with us your research experience and your first-hand knowledge.
I have presented MAC PCOS in the endocrinological meetings as well. So there has not been much. Obviously people are very possessive about illnesses. As PCOS is all endocrine, but there has been a lot of talk, but not much challenge on the science. Most of them do think that probably this is something we should be looked at.
Thank you. And as we do not have any more questions in the chat box, so I am handing over to our respected chairpersons for their concluding remarks. And after that, we'll be giving our vote of thanks to Dr. Nitin Gupta sir and Shobha madam.
Can I have one last question if time permits?
Sure, madam, sure.
It has been, well, the concluding remarks are that it's been extremely insightful and a wonderful way to look at how stress affects us in myriad ways, right from childhood onset, and gives rise to various kinds of syndromes which affect other organs as well secondarily. I just wanted to ask Dr. Hussain whether we should have an approach of something like a group focused strategy rather than individual psychiatry consults. The reason why I'm asking this is that we in our department had also done a similar study a couple of years back and was published by my colleagues, in which we did see almost 40% prevalence of anxiety and about 25% prevalence of depression. But the milder, I mean, when we looked at the severity of these symptoms, there were almost 50%, 60% had mild symptoms. And when we gave them the option of, seeking a consultation with us, I would say that barely, I mean, we could count on our hands as to how many of them came to us. So,
Definitely, absolutely necessary. I am somebody who believes that we are brain of medical science. We have to be in all branches and we have to be coordinating, but with science. We have to probably come out of cozy rooms, and we have to actually come with science and understand that we have a greater responsibility, because we are doctors of brain, and currently all the illnesses, whatever happening around, whatever is ailing mankind, has its etiopathogenesis in brain. The etiopathogenesis in the brain. If we have to correct them all, the answer lies in the brain. But we have to actually develop that science and that coordination with the people. We have to go and as I said, that because most of these patients are seen, the endocrinologist is at one place, the psychiatrist is at another place. There's no coordination. So yes, that's why probably the sciences will develop, and we actually will see them in a very coordinated way. We'll start exchanging ideas. People will start challenging our ideas. People will start debunking our ideas. That's the purpose, because the science develops from that. If we are not debunked, if we are not rebuffed, it will not develop. So it has to happen, and that's why I said that I made it a point to actually present my it at least in the 3 endocrinology society meetings in front of endocrinologists, and made them to ask me questions, and went back home and start studying about it, and then replied back, and trying to develop this model. And all of us can do that. All of us actually have that capacity as psychiatrists.
Right. Thank you so much, and many congratulations on your wonderful presentation.
Thank you so much, ma'am.
I think maybe I can add my thoughts here. I think very interesting questions asked, wonderfully discussed by the speaker, and very important comments given by my co-chairperson in the end, because I think they have echoed what I was pondering over. I think the biggest issue which we face here is that when we are talking, it's not only about PCOS and the link with psychiatric morbidity. What Dr. Arshad has tried to highlight and emphasize, and what Dr. Shobha Nair actually just pointed out, is that we are not still being able to bring together what we call as the consultation liaison model, which is the need of the hour. And that is why our patients keep on suffering. People tend to be precious about their own specialty and their own practices and the disease which they tend to treat. As Dr. Arshad mentioned, the gynecologists want to take PCOS as their own entity, and they don't want to look beyond that. The endocrinologists want to look at it from their own perspective. And if the psychiatrist tries to point out that there is an overlap, then they get dismissed, that this is not possible. And even if you try to bring any specialty together, quote unquote, the psychosomatic model, that becomes very difficult. And if we then try to introduce a biological component also to it, that is bringing together biochemistry or radiology or any other biological component, that makes it all the more doubly difficult. So I think that is where we are struggling with PCOS also. It may not be that complex an illness to unravel, but I think we ourselves tend to sabotage in trying to understand it. I think Dr. Arshad has highlighted certain components of PCOS and has tried to put forward a model. But yes, we do know that depression is probably the commonest comorbidity associated. Anxiety is also very commonly associated. Bipolarity is there. In that way, the mood anxiety complex. But unfortunately, there are lots of methodological difficulties associated in trying to conduct studies. And that is because what Dr. Shobha also pointed out, that we are not able to do proper studies, sitting together and planning out proper studies. And that is where the difficulty occurs. Otherwise, it is not impossible to carry out good studies and come up with good data, and in that way translate it into clinical methods of helping out our patients. I think we are still struggling to come up with proper hypothesis of why PCOS occurs. Some people talk about that there may be altered cortisol levels, problems at the level of the amygdala, prefrontal cortex, things which Dr. Arshad has also pointed out, which I don't want to repeat. But this conundrum can't be sorted out till we get our heads together and have a consultation liaison clinic operating, probably in that way. And I think that is the need of the hour. This has been going on for the last, I think, more than 3 to 4 decades, and we are still no further forward. Dr. Arshad has mentioned repeatedly that he's made multiple presentations, but I don't think he's had the luck of being able to get people together to do proper research in a integrated manner, from what I've been able to understand. But I don't think we should have a fatalistic approach. We should still continue to make efforts, because our job is to try to not only do research, cutting research, but also to try to help our patients. And Pcos is one such entity which does require it, because people tend to suffer in that way. But I think it's been a very useful and enlightening presentation, and I would like to thank IABP office bearers, especially the CME committee, and along with that, my co-chairperson, and especially the speaker, Dr. Arshad, for illuminating this area. And with this, I'll pass back to Dr. Shobha Nair for any concluding remarks before passing back to Dr. Prasenjit Ghosh. Dr. Shobha Nair, please.
I'm done. Thank you so much, Dr. Nitin Gupta.
Okay, so Dr. Prasenjit Ghosh, back to you, please.
Yeah. Thank you, sir. Thank you, madam. Before I give the vote of thanks, I would like to invite all of you to kindly block your dates on 2nd and 3rd July. The national midterm CME of IABP will be held at Mumbai, and it's a physical conference. So I invite you all on behalf of IABP to please attend the CME and make it successful one. On behalf of IABP and as the treasurer of Indian Association of Biological Psychiatry, I thank our speaker for tonight, Dr. Arshad Hussain, for such a brilliant presentation. I also thank both our chairpersons, Dr. Shobha Nair madam and Dr. Nitin Gupta sir, for sharing their thoughts. I thank all the participants for attending and contributing with their interesting questions and making this CME a very successful one. I thank all the office bearers, including our president, Dr. UC Gog sir, our honorary general secretary, Dr. Rukseda, our CME chairperson, Dr. G. Prasad Rao sir, for creating and designing this CME. I thank our office staff, Ms. Amita of MediSquare, for her contribution to this CME. I also thank the corporate partner for their academic grant for making this happen. So once again, I thank all of you on behalf of IABP, and with the permission of the President, if President Goksa permits, we can conclude for tonight's CME.